Right, morning everybody. Hello. Okay, hi, and thanks very much for coming, everyone. Well, my name's Kevin Dixon, and thanks for coming along to Shaping Future Care. They've asked me to chair this one, and I've done a few of these, and I've quite enjoyed them. And I probably know about a quarter of the people in the audience. Yes, probably. Yes, yeah. From other sort of consultations, and it's a real pleasure to be actually back in Newton Abbot. I'm the chair of Health Watch in Torbay, so I'm actually a volunteer. And I'll tell you why I'm a volunteer a little bit later. First thing I'd like to do is do the sort of general housekeeping things. So, we're not expecting a fire drill. So if the alarms go off, there is a fire, or something's going on. So the two fire exits are over there, and over there. The little boys' room and the little girls' room is actually downstairs, and there's a lift. So if you need it, just any time, just go out and get it. So we've done the teas and coffees. Everybody should have had a tea and a coffee, yes? And thanks to the folks in the room for organising that. Thanks, Laura. Thanks, guys. Appreciated. Right, so what I'd like to do is first of all look at the agenda. Has anybody got the clicky thing just to move it on for me? There we go. Right, anyway, as I said, my name's Kevin Dixon. I'm a volunteer, and I've actually been asked to chair this one because, well, for a lot of reasons, really. The main reason is I absolutely, passionately believe in the NHS. The NHS saved my life, and it saved my dad's life, and it saved my mum's life, and this goes back years. So every single person in this room is passionately involved, committed, and believes that we ought to have the sort of best NHS we can actually get. So that's really why I'm here. I won't go on too much, but the agenda this morning is welcome and introductions, that's me. So I'll just spend a couple of minutes doing that. Then we're going to come on to the presentation, which involves a video. And I'll get the panel to introduce themselves in a second. And then we've got a mixture of two different things. We've got a sort of open question and answer session after the presentation. So I'll be sort of rushing around and sort of thrusting this microphone in front of your face, a bit like The Voice. And then what we'll then do is go into sort of table discussions. A couple of reasons of this, and we were just talking about this earlier, about which is the best way of actually doing this. Now, some people like the sort of rows. But then other people have come to us and said the problem with putting people in rows is that some people just don't like talking in front of a whole audience, which is fine. So having the sort of small table groups gives everybody a chance to actually chat. Now, on each one of your tables, there is a facilitator. I'll do this again in a minute, but can facilitators stick their hands up and identify themselves so they... Brilliant, thanks very much, guys. And so the facilitator will be taking down absolutely everything you say. Any comments you make, any questions you have, and what we'll try and do is follow up with questions. Follow up those questions and come back to you. We're trying to really find out what you actually believe, what you think, what your concerns are, what your aspirations are, what your hopes are. And we'll close after about 3/4 of an hour, about an hour on those discussions. And then I'll just sort of wrap up. So there won't be a sort of second feedback, but there will be this opportunity to sort of talk individually. And the members of the panel and some of the other folks around the room and myself will just be floating. So if there's any particular questions, come and ask us, and I'll pull somebody into the groups. There'll also, I'll certainly be around a little bit afterwards, and I think can the panel be around 5-10 minutes afterwards just to chat to people individually? That's really great. So we want to be as open as we possibly can. Ask any questions you want, raise any issues that you actually want. And what I'll do now is just ask the panel to introduce themselves. So which end do you want? You just had a mouthful of water, so.
Good morning, everybody. I'm Dr. Tim Burke. I'm a GP in Chumley, and I'm the chair of Northern, Eastern and Western Devon Clinical Commissioning Group, which is one of the two clinical commissioning groups within the Devon STP.
Good morning, everyone. I'm Dr. Joanne Watson. I'm a consultant physician and I work at Torbay Hospital. I'm here as I'm Deputy Medical Director for Torbay and South Devon ICO, which stands for Integrated Care Organisation.
Good morning, everyone. My name is Liz Davenport. I'm the Chief Operating Officer for Torbay and South Devon Foundation Trust, and I'm responsible for the day-to-day delivery of services in both the acute and community services.
Good morning, and I'm Paul Johnson. I'm GP here in Newton Abbot, and I'm also chair of the South Devon and Torbay CCG, which is the other CCG that is part of this STP.
You can hang on to that then. Oh, you've got one of those, have you? Well, I'll just go straight into our first term. So, okay.
Great. Well, as I said, I'm a GP and I work here in Newton Abbot. And what I'd like to do before I go through some of the slides is just put this into the most important context. And the most important context when we're going through these discussions is our patients, is you as you experience being patients within the health system here. I have lots of people who come to me in my surgery and they say, do you know what? I was really ill, or my family member was really ill, and the service I got from these people or from this hospital or from these district nurses was brilliant. And it made such a difference. And I'm very proud to be part of an organization and part of a group of organizations that does that. But I'm also very aware that if we want those sort of stories to still be being told in 5 years, 10 years, 15 years' time, then we can't just carry on doing things the way we're doing them at the moment. We have to change, because to be able to do that for our patients and give them the best treatment that we want is getting harder and harder for reasons that I think will become clear as we come through. So in all our conversations, let's keep our patients central and make sure that all those good stories that they keep telling us can continue into the future. So first of all, what are we going to be trying to do today? Let's set some context. So the other context is why are they these things called the Sustainability and Transformation Plans, these STPs? And we'll go through that a little bit in the presentation. We're going to explain, in fact, my colleague Joanne is going to explain why we are focusing on hospitals, on emergency care, and on specialist services as part of this STP, as part of this plan. It's primarily today a chance, as Kevin said, for you to air your views, to ask your questions, to have an influence and an impact on the sort of decisions that we're going to be having to make in the future. We want to explain what we're going to do with those views. We want for you to feel confident that what you say will actually make a difference, will help us so that we do the right things by you. And then lastly, we will tell you how can you stay involved. This isn't just a one-off process, this meeting, and then we go away and you don't get any more information or contact or communication. There are ways in which we can keep this going and keep you a part of the process going forward. So first of all, about the Sustainability and Transformation Plans. So Devon has an STP, which is a 5-year plan to make sure that our services, our local services, are fit for the people of Devon going into the future. It's one of 44 plans which cover the whole of England. And these plans were developed as a result of the NHS publishing their document about what their 5-year forward view, their vision was. And they had 3 aims that they then passed onto the STP, and that was to improve population health and well-being, to transform quality of care and the delivery of that care, and to create a system that has sustainable finances. And so all 3 of those feed into the STPs, the 44 STPs, and particularly our Devon STP. The other thing I'd like to say is it's not all about the money. The money is the thing that hits the headlines. The money is the thing that lots of people talk about. But even if the challenges, the financial challenges weren't there, we would still be having to have these sort of plans. We've got to do things differently because lots of things have changed. People are getting older, people are living longer. We all want to live long and prosper, to quote some famous TV star. And we want as a health service to enable people to live long and to live long healthily and to recover to their healthy level once they get ill. People are now not needing to be in hospital for as long when they have a procedure or when they are ill than they used to be. A lot of things can be done as day cases that often had to be stayed into hospital. So things that we can offer and the sort of people who we are looking after are all changing. And so even if the finances weren't an issue, we would still have to think about how can we deliver this and how can we do things differently. And the other thing is, what are the benefits that we're going to get from it? And the first one we've got there is integrating health and social care services. Healthcare and social care go hand in hand, particularly for people with long-term conditions and particularly for those who are frail. And it seems daft that the two should operate separately. And one of the things that we really want to do through the STP is try and bring those two strands together, working together, so that both are working for the benefit of the patients rather than sometimes it seems and feels like they're in conflict with one another. We want to better meet the needs of an aging population, and I know that in the documents that you have on your table, it talks about just how many people are going to be living for longer and for how long, and what that growth is going to look like going into the future. And that's one of the key drivers, and hopefully one of the things that we can achieve with the STP is to allow people to stay healthy and to be looked after as they live longer. There are increasing demands in the services. I'm sure you've experienced it yourselves. Trying to get a GP appointment is getting more difficult. If you have to go in A&E, you turn up and there is a long wait, and those waits sometimes feel like they are getting longer. More and more people are looking for healthcare in the acute front door of the hospital. And it's on the news quite regularly that actually the number of people needing input from health and social care is increasing, and we've got to try and meet that demand. And the other thing is the way that we can engage with people is different. Technology is changing so fast. My son picked up his phone and he said, "Dad, when you're old and in a home," he said, "these things that you hold in your hands to make a phone call, they're going to be like records are to us now, obsolete." Things are changing so fast. And so why do we see that actually what we need is face-to-face with our doctor or with our nurse or with our GP? Why is that the standard thing that we're sticking with when there is video, there is texts, there's all sorts of new technological ways in which people can get the healthcare that they need? This slide up here is a list of lots of organisations, and I think the main thing to get from this is that you can see just how many people, how many organisations and how many specialist skills come together to make the STP. The STP isn't an organisation coming and telling all of these people what to do. It is the coming together of all these different organisations with their expertise, with their wisdom and their skills to shape what happens. And as well as all of those up there, you can see down the bottom, we've got 160 GP practices, all needing to contribute and all valued in their contribution. We've got our out of hours, we've got Health Watch who are here today, and we've got our patients as well, all forming part of that STP so that we pool all of those resources together to make the right decisions for our patients. I'm going to pause for a minute. You've heard enough of me for now. We've got a video, a 3 or 4 minute video, which just highlights some of the reasons why that I've been talking about and some more about why we need to change what we're doing.
There is already much to be proud of about health and social care services in Devon. Staff work hard to provide good care, local people are relatively healthy compared with other parts of the country, and local organisations already work together to meet the needs of local people. However, services are not keeping pace with the changing needs of local people, and it is becoming increasingly difficult to make sure that local people have access to consistently high quality care that is affordable and sustainable. There are a number of reasons for this. People in Devon are living longer, with increasingly more complex care needs that require more support from health and social care services. Some people have more health and social care needs than others. 40% of local people use almost 80% of health and social care. There are 400,000 local people living with one or more long-term conditions, and their needs are complex. Around 150,000 people have a mental illness. Doing nothing is neither affordable nor clinically sustainable. We will be more than £500 million in the red by 2021 if nothing changes. Although there have been some local successes in changing the way services are delivered, there are many challenges facing health and social care in Devon.
There are health inequalities across Devon. A person living in certain areas of Ilfracombe is expected to die more than 15 years earlier than someone living less than 2 hours drive away in Newton, Poppleford and Hertford.
Local hospitals are finding it difficult to deliver services for some of the most seriously ill people. These include stroke, maternity, A&E and children's services.
Less money is spent on health and social care in the most deprived areas. Over 10% less is spent on health care for each person in West Devon compared to North and East Devon, even when age and deprivation is taken into account.
There are too many people in hospital beds who don't need to be there. The longer people stay in hospital, the more likely they are to get complications. It is also expensive to keep someone in hospital when they don't need to be there. The main reasons for delay are people waiting for health or social care in the community.
Care needs to be more person-centred and coordinated, especially for people with more than one long-term condition. People do not get enough support to be independent and are going into hospital when this could be prevented. This is particularly important for end-of-life care, where most people would prefer to die at home, but only a quarter are able to do so.
This is also true for children. There are high levels of demand for child and adolescent mental health services, and there are still far too many children in care or in highly specialist placements, often many miles from home.
Services could be run more efficiently across Devon. Tens of millions of pounds is being spent on areas where staff may be able to provide the same quality of services but more efficiently. Too much money is being spent on temporary or agency staff in hospitals.
Around 95,000 people with a long-term condition also have a mental illness. These people consume a large proportion of the health and social care budget but still achieve poor outcomes. They're also more likely to die earlier in life compared to people without a mental illness.
There are difficulties with recruiting and retaining staff at all levels, making it hard to provide comprehensive and high quality services. Many staff are due to retire in the next 10 years, and local organisations already have high levels of vacancies and staff turnover in many areas.
People in Devon deserve health and social care services that are of the highest quality and are delivered as locally as possible. Local people should be supported to take responsibility for their own health as much as possible. If people do become ill, they should sit at the heart of a proactive, person-centred care system. Achieving this kind of transformation with the funding that is available is not an easy task. But by working together, the NHS and social services with other public, private and voluntary sector providers of care can get the best possible outcomes for local people.
Well, I see that several times, and every time I see it, I think that's really powerful. That probably speaks more powerfully about our need to do something differently than anything I can stand up here at the front and say, particularly because it's coming from patients who experience those services. But I'm going to press on anyway. The next slide, this is those three key areas that the NHS identified. And just to unpack those very briefly for you, the first one is talking about the health and well-being of our population. And we've talked about, we have an aging, growing population. We talked about already about the rising demands on our care system. And from the video, you saw that there are very definite health inequalities across Devon, all of which we need to address. The other element is looking at safe and high quality care, and we need to reduce the variability, what was once called the postcode lottery of what services you get and how good they are depending on where you live. We've got to prioritise mental health. mental health is as important as physical health, and the two often go hand in hand, and how can we make the two work better together? And the other thing is this phrase, the best bed is your own bed. A hospital bed was often seen as the safest place to be when you're ill, and for some people it's exactly the right place to be, but for many it is a risky place to be when they can get the same level of care and the safe level of care in their own bed at home without the risks of being in hospital and all the disruption that comes to a person's life when they are admitted. And the other thing that was mentioned within that video is just the vast sum of money that we have to be aware of if we do nothing. And that's that over 550 million by 2021, if we just leave things as they are in Devon. And we know that as we change things, that's got to have an impact. As we address those finances, that's got to have an impact on what we do. And the onus is on us to make sure that we do as much of that as possible without impacting on the quality and the safety of the care that you get. And the other element, again from the video, is making sure that that allocation is spent fairly across Devon so that everyone benefits equally. So then when we read our STP, and again, this is in your brochures, and each one of these priority areas is given more detail in the glossy leaflet that you have available to you. But just very quickly, if we start at the top, prevention and early intervention, that's all about communities working together, working with the voluntary sector, working with primary care, keeping people independent and healthy for as long as possible. When we look at integrated care, many of you will have heard a lot of conversation about that when we were talking about our community services and how we could make those more robust and better deliver care. There's an element there on primary care. We've got to help our primary care colleagues to continue to deliver the care for you. We saw there that 1 in 4 GPs are going to leave within the next 5 years. I think it was 5 years on the video. I'm not one of them, I don't think. But I do know a large number of colleagues who are, and we haven't got the number of people coming up through training wanting to do general practice. How do we bolster and support primary care and get people wanting to be GPs? And that's part of it. We've touched on mental health, and I'm sure there will be lots more conversations and lots more engagement with you over mental health, because we recognise that's a really important element, particularly getting it integrated in physical health. I'll come back to acute hospitals and specialist services. When we look at productivity, that's what inefficiencies, what waste is in our system that we can actually get rid of in order to help tackle that deficit that we are facing. And children, young people and families, they need as much attention, and they need these joined up services just as much as the older frail patient, just as much as the adult population. And so we will be looking in detail at those. Our main conversation today is going to be about acute hospitals and general services. I'm going to hand over to my colleague Joanne, and she's going to talk us through some of the detail on that.
Everyone, can you hear me all right? Yeah, that's working, good. So I'm here to talk about the acute services reviews, which are a specific part of the STP, and there are 3 areas that have been highlighted within the Devon STP that needed working on. These are the areas that were highlighted in the video that you saw because of the pressures each of those services are feeling. So we're talking about here urgent and emergency care within the hospital. We're talking about stroke services because these have changed enormously in a very short period of time. What we can do now for people who have had a stroke is vastly different from when I started as a doctor back in the beginning of the 1990s. And the last one of these, though not least by any means, is maternity, children's health, and the special newborn babies that need particular treatment as well. So what I'm going to do is take you through each of the 3 different acute service reviews and explain why they are important and what are the pressures that are going on at this time. Sorry, I pressed the slide a bit fast there. These are the 5 reasons that we actually looked at these 3 different services within the STP. So first of all, there is an increased need for treatment and care and longer waiting times. So what we can do is significantly greater than what we've been able to do in the past. And we need to be thinking about how we can deliver services which are fit for the 21st century. We've got hospital services which were designed really something very recognisable from when I was a junior doctor back in the 1990s, and I recognise the way that we deliver services is very similar to that, and yet life has changed enormously in that time. Paul was talking about mobile phones. Well, our children aren't really sure that life existed before the internet. And yet it is something that has become part of our lives in a relatively short period of time, and how can we use that? We have rising standards of care that we can expect to do. We can, new treatments which are coming online. So we're just pushing back all the things that used to be, we can't treat those. We can nowadays. It is remarkable how much medicine has changed, and yet we have to have a system which is able to deliver that as well. You will also know that there are many standards that are set within the NHS, and we can argue whether we think they're good standards or not, but the fact is that they are there, and we have seen improvements in care because we have standards to meet. And in this current times, with our current resources, we're struggling to meet those kind of waiting times that we've expected to be normal. It wasn't so long ago that it was quite normal to wait for your hip replacement for 2 years. And now we just think that's an absolutely shocking length of time to have to wait. And it's those kind of things that we do not want to see ourselves slipping backwards. But how do we use the resources that we have available now? And we are struggling with staff recruitment as well. That video highlighted those different areas where we are trying not to use temporary or agency staff. And I'll come on to that a little bit further to talk about that, because we'll see that as a recurring theme in these 3 different areas that we're looking at. So first of all, the first acute services review, just to look at in a bit more detail, is the hospital urgent and emergency care. So this is really thinking about how do we use our A&E departments over the 7 days a week, 24 hours a day. It is a national requirement that we are moving to better 7-day services. You will all know that most outpatient appointments happen Monday through Friday between 9 and 5. And that the hospital becomes a lot quieter at the weekend. Not really quiet, there's still loads of work going on, but we don't have the same levels of activity, and we don't have the same access to investigations that we would do, say, on a Monday morning compared to a Sunday afternoon. How do we use our assets better and deliver a 7-day service? So that's a big challenge to Devon to be able to do that across the board. Staffing shortages, I mean, it's not the most popular specialty to go into, but it is something that needs to be manned 24 hours a day, 7 days a week. So we need to look at how do we use the people that are there, because we do want that expertise to be focused in our A&E departments. Now, Devon has to see one of the biggest fluctuations in the people that are here. With our holiday people that come in, we don't have a quiet time in the summer like many hospitals would say that they do. We have a busy time because our population swells so significantly. How do we move to make sure that we can flex towards the busy times and enjoy the quieter times when they are there? But it is extra pressures that we have within our county. And the 4-hour target is a specific, I'm just standing a little bit too close to that. The 4-hour target is something that we are meant to be seeing people who come to our A&E departments to be seen and treated and have left the department within 4 hours. We're meant to get 95% of people through our ED or our A&E departments in that time, and it's a struggle. You will have seen over the winter how we were dropping to the lowest rate of that 4-hour target for the first time since it had been introduced 13 years ago. And we're seeing a much higher acuity of what actually comes into A&E as well. So as we push back the boundaries of what we are able to treat, the lives we are able to save, we're seeing people who need much more medical care when they come into our A&E departments. And we don't want to have to be taking people away from, we don't have to close our hospitals, we want to keep them open so that people can come and use local services. So these are the things that were driving the Devon STP to be looking at the Acute Services Review. They've been led by Adrian Harris, who's the Medical Director of the Royal Devon and Exeter Hospital, and they have been looking at these specific issues around hospital urgent and emergency care. Now, stroke services are another enormous pressure within our service. So this is an amazing movement in terms of medical care over the last 15 years. It used to be if you had a stroke, we could do very little for that. Modern treatments mean that we can actually help people to recover from what would otherwise be devastating strokes. But it's really important that people are treated within a 4-hour window if possible. We say time is brain, is the expression that the stroke services use. That the quicker you get there, the more likely you are to be able to have this brain-saving treatment. But it is difficult to give people. It takes a lot of medical nursing input to give these treatments, and it is a very specialised area. How do we deliver this specialised service across our whole geographical area? Different hospitals have slightly different approaches depending on the expertise of the teams that they have or the equipment that they have. How do we make sure that it's not a postcode lottery, that people can have access to the very best treatments? We know that we need to get people to hospital quickly, because if we can do a scan of their head and assess if they can have this brain-saving treatments, that every minute counts. So it's all about, on stroke services, being able to give equity of access to both the investigations and to the treatment, and to have real expertise about that recovery period afterwards. But how do we deliver it over a geographically diverse area with limited resources as well? So this service is, this acute review is being led by Dr. George Thompson, who is a medical director in North Devon. And the third area that's being looked at is maternity services, newborn babies, and paediatrics. These three different services are interdependent on each other, so we have to think of them as a whole. Staff shortages are really quite pronounced within all three of these areas. And it's been running like this for a long time now. And this isn't a local picture, this is a national picture. So it's not that Devon has done something wrong and we haven't been able to recruit these people. It is actually something that counties, hospitals all over the country are struggling with. It does also mean, because we have other staff as well, so thinking about midwives, specialist nurses on that special care baby units, and in paediatrics, we've got staff shortages in all of these groups of people. And if we're using agency, we pay a premium per hour for those people, and we don't get the same value for money as we do for using our own staff as well. There's no investment in the standards of delivering the service. So we're really keen to minimise our agency staff, because that's not the best use of our money. But it is something that we have to do in order to keep these services running. And again, babies are born 24 hours a day, 7 days a week. This is very important that we have this cover and these services available 24/7, with good choice for people, for mothers particularly wanting to deliver their babies in different ways and in different places. And again, we're seeing more complexity within these in a very normal part of life, being able to have a baby. We're seeing older women having babies. We're seeing multiple complex births as well. And women who previously might have had medical conditions which stopped them from having children, we're now able to support them through having a healthy pregnancy and good outcomes as well. But all extra pressures on the maternity services, which we need to think about in order to take things forward for our services here in Devon. So that sort of takes us to why we are here today, because we know that any decisions that we make locally about those 3 areas will be much stronger for involving people who will be using these services, who have used these services and want to give us their feedback about things that we wouldn't necessarily consider in the same light. We haven't made any decisions as yet, but by engaging with people and finding out your kind of views, we will make better decisions as well. This slide mentions that we have some decision-making criteria, and I'm just going to share them with you here. There are 8 different criteria, which really make sense when you look at them, that we are looking to deliver safe care. So that is all about when people come into hospital, they have the right treatment, and that they have it in a timely way as well. It's important that we understand the clinical effectiveness, the benefits that people get from the treatment. Are we delivering where we should be, and ensuring that people get good outcomes, improved outcomes as well as we look to the future. Access is really important, especially when we think about our Devon roads as well. But how do we ensure that people have access to these different forms of treatment or areas of care? As we look to the future, and this is a point that was made in the video, that we can't continue to provide services as we do. We have to think about different ways of being sustainable into the future. So I passionately believe that the NHS needs to continue, and that we are proud of what we do. And as Paul said, we want to look to the future as well. But how do we do that in a sustainable way? And that's how we're looking at redesigning our services. The acute hospitals have a very important role around training doctors and nurses to come through, so they will contribute to GPs training as well. So it's across the board that it is important that the hospitals are able to train our health professionals of the future, and we need to keep this capability there as well. Cost effectiveness is a really important thing. We have this kind of mantra about treating every pound as our own, and to be spending it to get value for money for the populations that we serve. Patient choice is really important, so that people can have a look and see what's available and understand the different services as well. And together it's thinking about what does it feel like to be part of, to experience the NHS, particularly in these 3 different areas. If you had to come in to any one of our 4 hospitals in Devon for whatever need, whether it was to have a baby, if you'd had a stroke, but that you would have that good care, and that people had a good experience and said, yeah, the NHS helped me and helped my family. And that's really why, where we are, what we wanted to share with you today about our thinking and about why we're looking at those 3 services. And I believe the next part is moving on to our question and answer session.
Right, panel, thanks very much for that, much appreciated. Right, comments, questions, anything that anybody? Yep, a gentleman over here, and I'll just pass this over. Sam did ask me to say that we will actually be recording this. We won't be able to identify who anybody is, but we really want to sort of find out. So if you'd like to give us a song before you start, please do. There you go.
Okay. Isn't one of the problems, in fact, most of the problem in national health is politics. Before I moved to Devon, I was a county councillor in Berkshire. And quite frankly, it's ridiculous that social care have to be funded out of council tax. It should be funded nationally. In other words, income tax should rise. And if we want services, we've got to pay for them. And I really do feel that the social services is at my age, it's certainly one of the biggest problems we're facing. Okay.
Is that all right? Yeah. I think for us to be able to care for you as we would want to, then having a social care system that can deliver and can work with us is crucial. I absolutely agree. As far as the politics of that is concerned, we have what we have as far as organisations. And that is, a lot of that is dictated to us. We have discussions, we have conversations with people more centrally, but then it's down to us to do the best with what we've been given, and that's very much what our conversation here is about, trying to influence the things that we as organisations can influence. I would encourage you, if you feel led to try and influence things more politically, then I would encourage you to do so.
I'll just pick up from an operational perspective, because as an integrated care organisation brings together health and social care in Torbay, and what that enables us to do is to create much more flexibility about how we use the total resource available to us. And already we can see the benefit of that to our local communities, because we can support people quickly by making rapid decisions that enable people to move into the right pathway of care for them according to their need, and we're able to flow the money in the right place to enable that to happen. So I do think we do have some advantages locally.
Thank you. Good morning. I just wondered, obviously you've outlined some of the difficulties that you're facing. Do you have any kind of proposals as to what this will actually look like, how you envisage you'll need to shape these things in order to meet these demands and needs? Are you going to have to concentrate services, or what kind of things are you going to have to implement?
So where we are at this point in time is in that consultation period. So we have identified these three areas, recognising the different sort of stresses within and demands, but we have made no decisions at this time. So everything is on the table, and we're looking at, for example, if we look at the maternity services, we've looked at how those are delivered differently in different parts of the country and internationally as well, with the clinicians working together across the whole of Devon to think about, this is what we need to be doing, how are we going to deliver? But no decisions have been made, and there will be further consultation about that as well.
Give me some exercise coming all the way over here. There you go.
Thank you. You mentioned about retaining trained nurses, doctors, etc. How are you going to go about keeping the ones that we train in this country, to keep in this country rather than go abroad? Of course, we've got lots of lovely doctors from all over the world coming to here, and that makes us feel that they want to come here. But how are we going to retain our own staff here that have been trained here rather than send them abroad?
Okay. So we're going to work our way along on this one, I think. If I talk from a primary care point of view, and then I will pass on to talk about our hospital staff. From a primary care and in the community, we've got to make it a great place to work. And I know there's been things in the news recently about how proposals are forcefully keeping people in. I'm not going to get involved in that discussion, because I think actually for people to work here, it's got to be something that they want to do and something that they enjoy and get a lot of reward from. The challenges within primary care are that it is getting busier and busier and harder to deliver the level of care that you want to for your patients. And when you know that you could be doing better, but you just haven't got the resources to be able to do that, whether that be financial or whether that be staff, then it can become a very hard place to work, and there may well be more attractive offers elsewhere. So what we've got to concentrate on is how do we make primary care in Devon the best place in the world to do primary care. Come and talk to me if you've got any ideas. I've got a few, but I won't go into those now.
Thank you very much. So from a provider perspective, we're really proud of the workforce that we've got. We have some highly skilled, very capable people, and we're really committed to retaining that skill and experience. Clearly, we are in an environment where we're making changes, and we need to support staff in making transitions to new ways of delivering those services. And I do think as a local community, we've got a really strong reputation in terms of our ability to provide training and to develop our staff, whether it's our skilled non-registered staff by building up our apprenticeship programs or the other postgraduate training programs that we offer, and we think it's really important we build on that capability. And the second issue is how you engage with and involve your staff in change, and we know that that's really important. So people's sense of value in the workplace is very much affected by the degree to which they feel engaged and involved in services, and we need to get that right as well.
I'm just conscious that we're talking very locally here, so I'm glad, Tim, that you're here to offer the Devon perspective. And so I'm going to build on what Liz had said, because we work within the same organisation. And I actually chose to come and work here, despite my aged face. I've actually only been working in South Devon for 6 months, but I chose to come and work here. It is a great place to work. We've just had the national survey back for NHS, and we scored very highly in that as a place to work. And that's what we're trying to sort of create, is that ethos of being very forward-looking and thinking about the problems. And actually, the staffing shortages that I was mentioned are national ones. There will be other parts in the country which could list things that we have completely covered here as well. So just to put some context, we're not bad compared to the rest of the country, but we do recognise that if we make it a great place to work for all staff, that they will come. And we have a great record for trainees who have come, who've worked here as a junior doctor and wanted to come back as a consultant as well. Absolutely, and I think you're right. It's been a real positive development for the peninsula that we have our own medical schools now, and people are choosing to come, and we have trainees that come down and stay down in this part of the country as well.
Thanks. I wanted to make the point we have 2 medical schools, and actually I think that having a single Devon plan and having all the organisations that were up on the screen a little while ago working together actually provides us with a strength, because actually if you talk to people about what they find uncomfortable and puts them off working in a particular area or specialty or a particular location, it's often feeling isolated and unsupported. And I think that some of our hospital specialties, some of our practices are experiencing that. And I think it's actually providing that network within a whole plan that will actually give us strength. Hospital services have developed as local services have developed in a way. It's quite different if you look at the number of specialists in a particular area in Derriford or the RD&E or Torbay or North Devon, and it hasn't arisen as a coordinated plan. So we have quite stark differences in how many of a particular specialty you might find consultants present in different places. And I think it's about starting to think about that, because actually that allows us to build a brand and build this area as a really even more attractive destination for people. The 2 medical schools help. We're going to get a new school of nursing starting in Exeter to complement the one in Plymouth. And Plymouth has been very forward as a university in training allied health professionals, physician associates, etc. So I think we do have a track record. We do just need to start to knit it together in one plan.
Hello there, Barry Stevens. You were on about, getting feedback from various groups. I'm actively involved in the PPG group for Teignmouth, and this is the sort of first feedback that we've had of anything going on in this area. I was just wondering why that we've never had any more information, because we get a lot of involvement with obviously patients coming through to our groups, and we could actively get some more feedback for you on what's going on. One of the things that I felt that you could do more active is to give a reassurance that there's, in our area, there's been a lot of closures of beds, cottage hospitals, maybe an assurance that there's going to be no closures of acute hospitals coming from this, all right? And, you know, I think we could help in that area from the PPG group, because one of the first things that they would do is get hold of us and say what's going on.
As a GP, if I answer the first section of that, and then I'm going to pass over to Liz to talk about the sort of assurances that you've been asking for. The first thing to say is that this is an early stage. So it's not that we are bringing you into the conversation at a late point in this process, that these discussions amongst the professionals, amongst the different organisations are still very early on. And actually, before we get too embedded in our ideas and our discussions, we want your input. And that's why we're here. And I know that Joe, who's at the hatch there from South Devon and Torbay CCG, works with a lot of PPGs in our area, and she is very good at trying to get you informed and get you engaged. And I would be very surprised if she didn't bring this to you and ask for you to get your involvement and get your feedback. I guess I've just volunteered her by doing that in public, but only knowing that that's actually one of her drives. So my hope is that from this early point now, moving forward, that we will try and engage with you through whatever means is effective. And PPGs are really useful, really powerful, really good voice of the patient for that particular practice. Yeah, thank you.
Thank you. So alongside the acute services review, and one of the other priorities, clearly we've been focusing on integration and development of our community services, and we have had a recent consultation around changes to those services, which have resulted in decisions to change the number of beds we have in our community hospitals and in our acute in Torbay and South Devon. What I would say in terms of the acute services review, no decision's been made, as Joanne made reference to earlier. We're at the early stage of this process. We are collecting views, we're collecting the opinions of a broad range of people that will inform the final decision. But at this point, there are no expectation that that will result in the closure of any of acute trusts.
Yes, good morning. Oops. The SDP is quite rightly, I think, putting a great deal of stress on prevention, early intervention and integrated care. Much of that integrated care, the articulation is that will be with third sector, voluntary organisations, community organisations, and that would inevitably be around early intervention prevention. How do you balance, how are you intending to balance those priorities with what would appear to be, at times of restricted financial capacity, what would appear to be a withdrawal in the commissioning environment from awarding contracts to community and third sector organisations, and trying to harvest whatever cash is available to protect your existing NHS resources? That's an understandable thing to protect jobs, but at the same time, the community needs reassurance, voluntary sectors need a reassurance that in fact you have an approach going forward which will be open to an increase in the commissioning of third sector and community organisations.
Are we on? Yeah. It's a very good point, and I think I recognise the tension that you're talking about. And one of the difficulties, I guess, that we face as relatively large commissioning organisations is how do we interface with what is necessarily quite a complex landscape of smaller organisations who actually generally and properly relate to a local community often, or a local community of what you call a community of interest, a certain group of people. I think we have not been very structured or organised in the past, and certainly in my time in New Devon CCG and previously in NHS Devon, I think at one point we had in excess of 300 contracts, ranging from the very small, a few £1,000s of a grant, to a local organisation, which will be vital for them to continue, right up to £500 million, to an acute trust potentially. So I think we haven't been very structured about it. So to get to what we might do differently, I think we have got some examples where we are starting with our reconfiguration of community assets, which we have been doing in the rest of Devon and in a similar way to South Devon and Torbay CCG. We're looking to create those, I'm banned from using the word hub, but I'm going to say it anyway, that these focal points, which may or may not turn out to be around the community hospital, so that you can actually have a focal point for local services to start to join up between health, social care and the voluntary sector. I think one of the things that we need to be better at is providing a more consistent ask of the community. What are the things that we would like to see the voluntary sector involved in? Now, we recognise that the voluntary sector may not be able to respond to all of those requests in all areas, which in itself creates a bit of a problem. But I think we need to be more clear and more consistent in what we're putting out there as the offer, and what we would like people to get involved in supporting, so that we can actually get, as Paul talked of earlier, a more equitable distribution of both our resources and access to services for people. So I don't have a ready answer, but I recognise the tension, and I think we are trying to get better at doing it. I would just put it out there, if leaders and members of voluntary sector organisations who are here or elsewhere want to bring forward ideas, then we're always receptive.
Tim, I was just asking you to reply there for the Devon perspective, because this is the Devon STP, but I know, Liz, you're desperate to say what the local situation is.
So thank you. So absolutely echoing everything that Tim said. We, as part of the implementation of our community model, are establishing what we are calling health and wellbeing centres. But those health and wellbeing centres aren't just about what's delivered by the statutory health and social care system. They're partnerships that are being established with a whole range of other community providers. And to make that real, we've already created some partnerships to create what we're calling health and wellbeing coordinators, for example, who work as part of those integrated teams with staff working in the voluntary sector, really establishing those preventative and early intervention opportunities for people in their local community. So we see that absolutely being pivotal to how we take forward the work within our local community.
Sylvia, on the way. There we go.
Just really following on from the theme that you've just been raising, of course, district councils do have an important role in providing the health and wellbeing agendas. And what is your interface with public health representatives, certainly from Devon County Council? And as far as district councils are concerned, of course, we have a lot of the facilities and sports facilities that, you're looking for everybody to take care of their own health and keep as healthy as they can. And there's a great move now towards social prescribing by GPs, who will actually prescribe exercise, and district councils are very receptive to this, to making their premises and facilities available for GPs to prescribe for particular patients who need those services. So there is another arm to the NHS, isn't there, the public health agenda, and you've just mentioned health and well-being. And I just wonder how important you feel the interface with the public health representatives in Devon and elsewhere is to making sure that this transition is successful.
I'm just going to start with a local example. It's always good to earth things with local examples, and then for the wider engagement, I'm going to pass on to my colleagues just to give them warning. The microphone's leaving me very shortly. I've been, before I became the chair, I was the lead GP for the Newton Abbot area, and I spent a lot of time with Teambridge District Council looking at what can we do from a wellbeing point of view. And it has culminated this year in a pilot that we're undertaking, which is looking at people who have got what we term as pre-diabetes, where they haven't quite got diabetes, but if we don't do anything, they inevitably will do. And referring them for lifestyle and exercise intervention up at the leisure centre. And so that is about to get underway with primary care and the council, the public health arm of the council, working in collaboration for those particular patients. So there are some really real things doing. As far as sort of the higher level of discussions, I'll pass that on, but it's just to know that although we talk a lot in theory, there are really things happening on the ground that demonstrate that partnership is really happening.
Thank you. Structurally, there are some really important groups that meet where public health are key to the discussions. So I'm talking about health and wellbeing boards. I think Paul will be joining the Devon Health and Wellbeing Board with myself. So Director of Public Health for Devon is present there and key input. We also make sure that I'm sure this is replicated in South Devon and Torbay CCG, we have our public health colleagues involved in our governing bodies and discussions, and their information and their insights into the well-being of the population, the health of the population, and what would improve the health and well-being of the population. Those are brought into our commissioning decisions. So, as well as the practical commissioning of services and developing of joint posts, etc., there is the very start of the process of how do we decide what we need for our local people involves public health very firmly in there. And I think I would say that it's been a bit of people may not be aware, but public health moved from the NHS to local government as part of the changes in 2013. That was quite a sort of a change for them particularly, I think, but also for us in the NHS. In many ways I can see the logic. I think it makes sense for public health to be embedded in local government, but it means that we do need to think about how we interface with those and how we use the information that they can provide for us to shape the services which we then go out and commission.
One or two more questions and then we'll close. If I go to this gentleman, then come back to, if I go to, right, this gentleman, that lady, and then come back to Sarah, and then we'll sort of move into the group sessions.
Good morning, Robin Sutton from Newton Abbot. If I'm following the slides correctly, we're facing an overspend on acute services of 305 million by 2021. And in the context of the acute services, I'm sure you'll get a consistent feedback from these events that people are very protective of their local acute services. That's certainly my expectation. And then it takes us on to the next stage. If that's the feedback, how, if we're going to maintain those local acute services, how we're going to make any inroads into this overspend. And in the paper you talk to vulnerable acute services, and I just wonder if the panel can elaborate more on what that means, please.
Thank you. And as we go forward, we are going to have to make some specific decisions around how we do use our resources, and staying the same is not an option. How we will save that, there is not that much money coming through, and that's part of our problem is the flatline funding, and so that's the projection, and the figures you're quoting is for the whole of Devon as well. So looking at where we are now and where we're going to be in terms of finances, we do have to be thinking about how are we going to use what we've got. And I agree with you, acute services are needed in all parts of Devon. So here in South Devon, there is a single hospital, but we have Exeter and Plymouth on either side as well. But the criteria that the STP is using to make its decisions are clear and transparent so that we can be able to explain the decisions that are made as they come along. I think that Torbay Hospital will absolutely continue to be our local hospital. What the services that are provided there is, you know, where the STP is, and how radical we don't know yet, but it is something that a lot of the services will be continuing as they are at this point in time. And I think it's that consultations that we need to be having with the public, explaining how the decisions are made as they come through, but they haven't been made as yet.
Shall I just pick up the specific question in relation to what makes a service vulnerable? So we've identified that these 3 sets of services as being vulnerable at the moment because we've got significant workforce issues which have in some areas have been around for some period of time, where we have not got an immediate solution to that. And we have a responsibility as a health and care system to make sure that we can sustain the delivery of safe and effective services and to be able to make them available when patients need them, which increasingly requires us to focus on 7-day working. So at the moment, we've got these 3 services where we feel there is a risk to delivery of those expectations. And therefore, those are the areas that we're focusing on first. The solutions that we may generate may be cross-system solutions, but that's exactly what we're out talking to people about, is what would good look like in the context of our requirement to deliver safe, effective services to our local communities, given the challenges that we face.
Hi, Chris. So my question really is kind of follows on from that last question in a way, in that our population in this area is dispersed over a wide geographical area. And so I'm wondering, when we're thinking about the impact of streamlining services, that's obviously going to impact on existing health inequalities. So I was particularly thinking about that with respect to accessing services and for travel for people. Obviously, if we streamline services, so for example, I was thinking if you have people who are having stroke services and they need the support of their families, if we're going to streamline those, which sounds to me like possibly moving further away, certainly from some local populations, you know, those people have greater travel burden then in order to support those family members. And I just sort of wanted to highlight that. I'm not suggesting there's a solution to it, but just that if we're already thinking about the health inequalities in the area, that is something I'd like to sort of bring up there. Really.
Absolutely. And actually, I think the stroke services is a good kind of description, a good example here to kind of explain that one a little bit further. So we could look at some models that have been set up to kind of address those problems that you're saying. In stroke, nowadays, we can give some quite difficult treatment, and it's very intensive to give the treatment and even an operation on the brain. So we only have one neurological centre within the area. So that's Plymouth with neurosurgeons there and their kind of equipment. But that's very specific. Now, if we can get people to Plymouth really quickly, and that, you know, we want people to present early, to do the basic investigations at one of the hospitals, and get them to the really specialist centres if that's what's needed. The idea is then that they would quickly come back to their local hospital. So that could be, you know, here it would be South Devon, so that actually their time away would be very short. And that's the kind of pathways that we're thinking about, is how do we quickly get people to a hyper acute place, but recognising that they, as quickly as possible, they also need to come back, because the additional travel is such a stress for people as well. So we're thinking about every detail of the pathway as well.
Just a really simple one for my own mind. Lots of people ask me quite frequently what well-being actually means, and I just wondered, with 4 experts there, you could explain to us in simple terms what well-being actually means.
We'll put definitions on here,
All right.
so I'm going to leave that to me.
Okay. I think well-being is, the simplest term is it's the converse to being ill. We talk a lot in the health service about illness and about disease and about treating those. Well-being is either living without those illnesses, so therefore preventing them from developing in the first place, or enabling people, if they have those conditions, minimizing the impact that those conditions have on that person's daily life and on the things that that person wants to do, and therefore giving them a sense of well-being despite the conditions that they are living with.
I think that was very good. It's a total all-round feeling of being able to engage with life and to do the things that you want to do. And interestingly, we have a national health service. We have chosen health. It's not a national sickness service. And I think that sort of speaks to the well-being part of why we think that that's important.
I just wanted to amplify that brings in what has been stressed earlier about the mental health aspect. I think people can have a sense of well-being even when contending with quite significant illness and disability. But one of the key features of making that happen is how you support them psychologically and how you give them that sense of support being there for them. So I think it really does play to the, it's the mind and body, it's the mental health and the physical health aspects of an individual.
I think we're just about there. Any other ones? What I'd like to do is actually go into the smaller groups now. Can I just say thanks very much, panel? That was really interesting, and also thanks very much to everybody who asked questions. And I'm particularly pleased to see patient participation groups here, and I'm the chair of mine in Torquay. So thanks, guys. I actually see PPGs as the basic building blocks of sort of patient engagement. So it's nice to have you here, and thanks to elected members for their comments. So thanks Sylvia and Sarah. Let's go into groups. Hands up the facilitators, just so you can identify them. And what we'll do is we'll do about half an hour, 3/4 of an hour. We won't be losing anything. We'll be available to sort of drop in if you've got any specific questions. So I'll leave it up for the next half an hour, and thank you very much.